Reactivity, about end feel, things of that nature, guided us to an area of dysfunction. But the PPIVM is a little more specific. It actually sets the stage for what we're going to do. So that's why I prefer it. So we find restriction and rotation right at 2-3. That's what we're going to do. Now, if it's really reactive, we're going to reduce the reactivity and use some modalities. Maybe do an indirect treatment session or two, calm things down. Eventually, that's the direction we're heading. So we'll do more of that. We're 1 through 4. At this point, you should know how to find 1. Come down the neck. The first large spinous process you feel is 7. And if you're not sure if it's 6 or 7, then extend the head back without the retraction. Just extend the occiput. The upper neck extending will force the lower neck into flexion. 6 will move away from your finger in an anterior direction. 7 won't. 7 will stay. So you find 7, then you go down to 1, and then you're at the interspinous space of 1, 2. A couple things that, not recipes, but just a couple of guidelines. When we assess side bending, in a little while we get down to the mid and lower rotation. Rotation here we're doing in the upper thoracic. We place our palpating contact on the contralateral side of the interspinous space. So rotation contralateral. Side bending ipsilateral. Just keep that in mind. When we do side bending later, doesn't mean you can't reverse it. This is just the way I think it's easier to learn it. So at 1, 2, I'm going to put my listening contact. I'll use my thumb. You can use your middle finger. I'm going to put my thumb right between 1 and 2, just on the left side of the interspinous space. Now, posture is important. Now, just go into a slump sit. She doesn't do a slump sit. I've introduced, or she's introduced motion into the upper thoracic from below. And that would be consistent with type 3 mechanics. Friat's third rule. Because we've introduced flexion, and that takes slack out of the system. Now I'm not getting a true read on rotation because we've contaminated the area by introducing motion. We've got to start from neutral. So the patient's got to be sitting up straight. So I'm just putting 1 and 2, and then I'm going to take the head, recruit C1, you're about 3 degrees of rotation OA, so it's not much. And then right away A is going to kick right in. That's about 45. Then we're going to be in the lower neck. Before you know it, you're going to be in the upper thoracic. So we're going to use the head and neck to recruit the upper thoracic spine, as we did with extension. Come to about 45 or 60, and T1 will just begin to move. And the better you feel, the better your skills in palpation and mobility testing, the earlier you'll feel movement. If you have to go all the way to the end to feel it, then you're missing a lot. So just back up, really close your eyes, try to really get a sense of whatever it is you're feeling. You don't have to understand it, but just, oh yeah, I can feel it just starting to do something. I'm not sure what it is, but I feel something going on. That's, at this point, good enough. You feel something happening there. There it goes. Just a little movement of T1 spinous to the left. I go down to 2, 3, and I feel 2 moving on 3 to the left. 3, 4, and 4, 5. Okay. Trying to get a sense of presence of a dysfunction, of impairment. So we're going to look at the quantity. It's not much, maybe an eighth of an inch, slightly more. The quality, how that feels. Is it free, tight, is it rough, down? The end feel. Get to the end. Does it have a little give to it? Every normal joint should have a little end play. Should have a little spring as compared to just feeling hard and stiff. Reactivity, if there is pain, what comes first, stiffness or pain? Stiffness first, low, pain first, high, together, moderate. All these things you're getting, just there's probably more than that. I mean, you can continue to brainstorm and come up with more things you're feeling besides those. Those are the main ones. The quantity, the quality, the end feel, and the reactivity. Then we go to the other side. We put our hand on the right side and we do 1, 2. Spend maybe 15 seconds. 2, 3. Back and forth. 3, 4, and 4, 5. Yep. The head and neck can recruit the spine to about T4. Beyond that, we're going to have to change our technique. Now, if you were doing the transverse pressure, that would correlate, because this is another way of doing rotation. This is weight bearing, that would be non-weight bearing, but there should be some agreement in your findings between the two techniques. It's nice to have more than one way sometimes to do things. All right? Now, before we have you do this on each other and actually mobilize it, I would like you to get a sense of your motion and rotation. Many people, they don't move into their upper back. They're forward, they're locked up in extension above, they're locked in flexion from below, and they maybe move down to 4-5 or 5-6, and that's it. But when you get them in neutral, and then they start to feel the potential to move into the upper back, their movement is altogether different. Now when they back the car up, they can actually see behind them a little bit. You're walking at night, you know, in the city, and you're 3 in the morning, you shouldn't be walking where you are by yourself. If you are, fluid, but you got to sense someone